Hello, everyone. Welcome to another topic of clinical case discussion. And we are looking at varicose veins today. We know that the basic dictum is there is no clinical subject without any fundamentals. So, just like for any other topic, we will have a brief overview about the anatomy of venous drainage of lower limb, and then we will move into the actual case sheet and then further details. Okay, right. So before we go any further, we need to understand the venous system or venous drainage of lower limb is divided into three categories, and with which basis of the anatomical structure it has been divided into categories and all we will see. So we know that veins of the lower limb have been divided into three main categories. One is superficial venous system, second one is deep venous system, and third one is perforators or otherwise called communicating veins. And we need to understand there is a deep fascia usually at many places in the body, like that. There is a deep fascia in leg also. Whatever the structure or whatever the vein that is present superficial to this fascia is called superficial venous system, and whatever the vein that is present deep to this fascia is called deep venous system. Okay, so this is something we need to understand. Right, next, what are the important superficial veins we have in lower limb? So first one is great saphenous vein, which is otherwise called long saphenous vein. Second one is short saphenous vein or small saphenous vein. And coming to deep veins, we have mainly anterior tibial vein. Second one is posterior tibial vein. Then fibular vein, which is otherwise called peroneal vein. And all these three will join together at the popliteal fossa to form popliteal vein. And this popliteal vein will continue as common femoral vein or superficial femoral vein, which will again will be united or which will be joined by deep femoral vein to form common femoral vein. And this common femoral vein will continue as external iliac vein. I'll show you the figure. So, and now coming to perforators, there are so many perforators in the lower limb, but only few are named, and we need to remember those names. Okay, right. So, this is the origin of great saphenous vein. As you can see here, it is formed mainly by your dorsal venous arch and medial marginal vein. So, this will be fused together to form the great saphenous vein at the level of dorsum of the foot, and it will continue. It will be coursing at around 2 centimeter anterior and superior to the medial malleolus, and it will further ascend up. Okay. Now, there are two important named veins we need to remember here. One is called Giacometti vein, which is nothing but cranial extension of small saphenous vein. Normally, great saphenous vein will terminate at the level of saphenofemoral junction, which is 3.75 centimeter below and lateral to the pubic tubercle. That is called saphenofemoral junction. And similarly, short saphenous vein will terminate at a point called SPJ, which is saphenopopliteal junction. Sometimes this is the actual most common variation which can be there with reference to saphenopopliteal junction. Sometimes this short saphenous vein will extend further cranially, and that cranial extension of small saphenous vein is called Giacometti vein. Okay, right. Next, another named vein we need to understand is something called Leonardo vein, which is nothing but your posterior arch vein. You can see here, this is the posterior arch vein, which is always called Leonardo vein. Okay, right. Next, these are the deep veins that we were talking about. So first one is anterior tibial vein, posterior tibial vein, and fibular vein. All these three will fuse together to form popliteal vein, which will continue as femoral vein, and that is again joined by your deep vein of the thigh, which forms the common femoral vein. This common femoral vein will continue as external iliac vein. One important point we need to understand and remember is that this great saphenous vein will terminate into common femoral vein, and this point is called saphenofemoral junction. Okay, so one is saphenofemoral junction where long saphenous vein will terminate, and another one is saphenopopliteal junction, which is very much variable, and that is where your short saphenous vein will terminate into this popliteal vein. Okay, right. Next, So I told you there are many perforators in lower limb, but there are only few named ones, and we need to remember those named ones. So one is at the level of ankle, it is called May and Kushner perforators, and above the ankle, 5 centimeter, 10 centimeter, 15 centimeter from the ankle, it is called Cockett's perforators. And if you take this is the knee joint, B for below knee, B for void. So below knee is your void and above knee is your dod. Then at the level of Hunterian canal or adductor canal, it is called Hunterian perforators. Then the other one is saphenofemoral junction. Okay, so we can easily remember these named perforators from below upwards with the help of a mnemonic. Most common by Dhoni. Most common by Dhoni. So M for Maykusner, C for Cocket, B for Boyd, D for Dodd, H for Hunterian perforators. So this is below upwards. We can remember the named perforators. Okay, right. Next, coming to physiology of lower limb venous drainage. This is something like in upright posture, all the venous blood from the lower limb has to be drained into the right heart. How is it happening? There are many contributing factors which will facilitate this venous drainage of this lower limb. Okay, so the first one is pressure gradient. In upright posture at the level of ankle, in resting state, there would be somewhere around 100 millimeters mercury pressure. Whereas if you take the right atrium, it will be something like a negative pressure at the level of right atrium. Okay, so the gradient of this pressure is facilitating the venous drainage. That is the first point. Second one is Visiter of circulation. What is Visiter of circulation? Let's say, for example, you have got a named artery here. Wherever you have got named artery, in the adjacent area, you will be having a vein. So you know that arteries are pulsatile. So whenever this artery is pulsating, there is this vein, adjacent vein, which will be exerted. The pressure will be exerted by this pulsating artery on the adjacent vein. That is called Visiter circulation. Then, the same is called transmitted pulsation from the adjacent arteries. Then the other one is venous walls. The veins have got so many walls present in the lumen of that vein. So this valve is nothing but a modification of your modified endothelium, or this is something but your tunica intima. Okay, modified endothelium, or which is nothing but your tunica intima. Okay, right. Next one is calf pump, which is otherwise called peripheral heart, which is nothing but your soleus muscle. Okay, then the other most important factor is negative intrathoracic pressure, which will be having a sucking effect that will be facilitating this venous blood from the lower limb into the right heart. Okay, so these are the walls we are talking about. In closed posture, in normal patient, there will not be any retrograde flow, that is from upward to lower direction. There will not be any flow of the blood because the valves are competent. Whereas whenever this valve is becoming incompetent, whenever it is becoming incompetent, then there will be a gap, inadequate function of this valve, which will lead to reversal of the blood flow from the superior to inferior aspect. Okay, right. So this is the calf pump we are talking about. This is the soleus muscle and gastrocnemius muscle, mainly soleus muscle. Whenever the pump is acting, this will exert pressure on the vein that will facilitate the venous blood upwards.